Every single year, more than 15 million elective surgeries are performed on adults over the age of 50 in this country alone. Not emergency procedures, not cancer, not trauma, elective, planned, chosen. And a significant portion of those patients sit in my office months later, not recovered, not relieved, but asking me a question I wish they had asked before they went under the knife. Dr. Candace, did I actually need that? And the honest answer, the one that costs me referrals and makes certain colleagues uncomfortable, is no. In many of those cases, the answer is no. If this channel is new to you, it takes 5 seconds to subscribe, and we are working toward 200,000 subscribers who deserve to hear what the system will not say out loud. The healthcare system generates revenue from visits, procedures, and prescriptions, not from patients who solve their problems at home with correct information. What I am about to tell you, no one in a clinic waiting room is going to say. So stay with me. Every word of this matters. Picture this. You have been living with the pain for 2 years now. Some mornings you wake up and it is manageable, almost forgettable, and you think maybe it is getting better on its own. But then a bad week comes. You are standing in the kitchen at 7 in the evening and you cannot find a position that does not hurt. You have tried the injections, you have tried the physical therapy, the anti-inflammatories, the braces, the topical creams that smell like a chemical factory. Your family doctor sent you to a specialist. The specialist sent you to a surgeon, and the surgeon had a solution. He had a date, he had a consent form, and something in you felt relief, just having a plan, just having someone who seemed certain. I see this in the eyes of hundreds of patients, and almost every one of them says the same thing. I just wanted someone to fix it. Let me be direct with you. The idea that surgery is the logical final step when everything else has failed is a lie. It is a dangerous illusion, and it needs to be shattered right now. Most people believe that if conservative treatments have not worked, surgery is the reasonable escalation. They believe the body has a structural problem, and the structural problem requires a structural solution. They have had injections, medications, imaging, and consultation, and the imagery showed something, a tear, a narrowing, a protrusion, and the surgeon pointed to it and said, that is the source. So they signed. What they were not told, what almost no one in that office visit had the time or the financial incentive to explain, is that many of those structural findings exist in people with zero pain. They were fighting the signal, not the source. Your MRI is the sensor. It is showing you a finding. It is not automatically showing you a cause. Before we go further, I need to say something as a physician with over 20 years of clinical experience. There are symptoms that should send you straight to a doctor, not to a video. If you have bowel or bladder dysfunction alongside spinal pain, that is a neurological emergency, and you need to go to an emergency room today. If you have unexplained weight loss with bone pain, that needs imaging and a specialist visit this week. If you have chest pain, jaw pain, left arm numbness, you stop this video and you call emergency services. These are not the situations I am addressing here. If none of those apply to you, you can breathe. You are going to be fine, but the quality of that life is worth protecting. Now let me tell you what is actually happening, and I want to be precise about this because the mechanism is what changes every decision that follows. Here is what is happening in your body right now when you are told you need one of these 5 procedures. The human body produces a phenomenon called nocebo effect alongside its better-known twin, the placebo. Nocebo, from the Latin meaning I will harm, is the measurable, documented physiological response to negative expectation. When a surgeon points to an image and says, that is your problem, the brain, specifically the anterior cingulate cortex, which is the region responsible for pain processing and threat assessment, begins to amplify the pain signal from that location. A 2017 study from the Dartmouth-Hitchcock Medical Center showed that patients who received a structural diagnosis before surgery reported significantly higher pain intensity at that site post-surgery, compared to patients who received the same operation without pre-surgical labeling. That is not psychology. That is neuroscience. That is a measurable change in the way your nervous system processes input. And here is where it gets critical. I need you to pay close attention. Because the 5 procedures I am about to describe are not fringe or rare. They are among the most commonly performed operations in adults over 50. And the clinical literature, published in peer-reviewed journals, not alternative health blogs, not wellness podcasts, has repeatedly questioned their effectiveness compared to non-surgical management. I am not telling you surgery is never the answer. I am telling you that for these 5 specifically, in the majority of cases, the evidence does not support the knife as a first-line resolution. The first is lumbar spinal fusion for nonspecific lower back pain, and I want to define that term carefully. Nonspecific means there is no identifiable fracture, no active infection, no tumor, and no confirmed neurological compression with functional loss. It means back pain that showed degenerative disc disease on imaging, which, by the way, is present in over 80% of adults by age 50, whether they have pain or not, according to data published in the American Journal of Neuroradiology. Spinal fusion, specifically the procedure involving pedicle screws, which are titanium anchors drilled into the vertebral bodies, and interbody cages, which are structural spacers packed with bone graft to promote vertebral joining, is a significant surgery. The recovery is measured in months, sometimes over a year, and the outcome data is sobering. A landmark study published in the journal Spine found that outcomes for lumbar fusion in nonspecific chronic low back pain were not statistically superior to intensive rehabilitation at 2-year follow-up, not better. At the price of surgical risk, hardware complications, adjacent segment disease, where the vertebrae above and below the fusion begin to degenerate faster, and in some cases, failed back surgery syndrome, a recognized clinical entity where pain becomes worse after the operation than before. I have seen this in the eyes of hundreds of patients. The X-ray shows hardware, the back still hurts, and now there are fewer options. The second procedure is knee arthroscopy for degenerative meniscal tears. The meniscus is a C-shaped fibrocartilage disc. Think of it as the shock-absorbing pad between your femur and tibia, the upper and lower leg bones. When imaging shows a tear in patients over 50, the reflex is often to scope the knee, to go in arthroscopically, using a small camera and surgical tools to trim or remove the damaged portion in a procedure called a partial meniscectomy. This is one of the most performed orthopedic procedures in the world, and the evidence against its routine use in older adults is now overwhelming. A 2013 study published in the New England Journal of Medicine, one of the most rigorous trials in this area, randomized patients with symptomatic degenerative meniscal tears into 2 groups. One group received arthroscopic surgery. The other received a structured physical therapy program. At 12 months, both groups had improved equally. There was no statistically significant difference in pain or function. The surgery had not outperformed physical therapy. And right then, the picture clicked into place for me when I first read that trial. I had been taught in training that visible tears required surgical intervention. The data said otherwise. The third procedure is cardiac stenting for stable coronary artery disease without acute symptoms. This one is controversial because it sounds life-saving, and in some contexts, it absolutely is. Stenting, the placement of a small mesh tube inside a coronary artery to prop it open, is genuinely indicated in the setting of acute myocardial infarction, what most people call a heart attack in progress. I am not touching that. What I am addressing is elective stent placement in patients with stable angina, meaning chest discomfort on exertion that is managed with medication, no acute event, no enzyme elevation, no active clot. The Courage trial, published in the New England Journal of Medicine, followed over 2,000 patients with stable coronary artery disease. It compared optimal medical therapy alone against optimal medical therapy plus stenting. The stent group did not have fewer heart attacks. They did not live longer. The difference was a modest short-term improvement in angina symptoms in the stent group, which largely equalized over time. That is not a fringe finding. That is one of the most cited cardiovascular trials in the past 20 years. I want to tell you about one of my patients. I will call her Maricel, 61 years old, retired school teacher, not someone who complains easily, and only comes to see a doctor when she is past the point of managing. And she was past that point. She had been living with knee pain for 3 years. She had gained weight because the pain limited her walking, and the weight was making the knee worse. She had imaging that showed a degenerative medial meniscal tear, and a surgeon had told her the tear was the source of her pain and offered to scope the knee. She came to me for a second opinion. I asked her one question: "Has anyone measured how you walk?" She looked at me like I had asked something unusual. No one had done a gait analysis. No one had evaluated the hip abductors, which are the muscles on the outside of the hip that control the alignment of the entire lower limb, or the vastus medialis oblique, which is the teardrop-shaped portion of the quadriceps responsible for tracking the kneecap. She had a significant weakness in both. Every step she took was loading the medial compartment of her knee disproportionately because her alignment was off, not because of the tear. I said to her, "Maricel, your tear may be real, but it may be a passenger, not the driver." She started a targeted 12-week neuromuscular rehabilitation program focused on hip and quadriceps repatterning. She did not have surgery. At 6 weeks, she told me the pain had reduced by more than half. At 3 months, she was walking 2 miles a day. The tear is still there on her MRI. It does not matter. It never was the source. Her case is not unusual. It is, in my clinical experience, the majority. The fourth procedure is the surgical implantation of a spinal cord stimulator for chronic pain before exhaustive conservative options have been tried. This is a procedure where electrodes are surgically placed in the epidural space, the area between the spinal cord and the vertebral bones, and connected to a pulse generator, essentially a battery implanted under the skin. The device delivers electrical pulses intended to modulate pain signals traveling to the brain. For certain specific conditions, refractory failed back surgery syndrome being one of them, the evidence is reasonable. But I am seeing patients who are being offered this procedure after only 12 to 18 months of pain, before they have completed a full course of pain psychology, graded motor imagery, centrally targeted pharmacological management, or multidisciplinary pain rehabilitation. The procedure involves surgical risk, infection risk, hardware failure, lead migration, and the psychological burden of managing an implanted device. It should be a late-stage intervention. In too many cases, the financial incentives in the system are accelerating patients toward it faster than the evidence justifies. There is no billing code for what I am about to tell you next. The fifth procedure on this list may be the one that generates the most pushback. It is elective spinal decompression surgery, specifically laminectomy, which is the removal of the lamina, the bony arch on the back of a vertebra, to relieve pressure on spinal nerves for lumbar spinal stenosis without significant neurological deficit. Lumbar stenosis, the narrowing of the spinal canal that occurs with aging, causes pain, stiffness, and sometimes the symptom called neurogenic claudication, a heaviness and cramping in the legs that worsens with walking and improves with sitting or bending forward. In patients who have lost the ability to walk a meaningful distance, who have confirmed neurological dysfunction, who have failed extensive conservative management, decompression surgery has genuine evidence. But for patients with moderate symptoms and preserved function, the SPORT trial, a large multi-center study published in JAMA, found that at 4-year follow-up, patients who chose non-operative management caught up substantially with surgical outcomes in terms of pain and function. The window of surgical advantage narrowed considerably over time. Most people believe imaging findings equals surgical necessity. Here is why that is a mistake. The spine changes with age. Every spine. The presence of a finding does not establish it as the cause, and the removal of a finding does not guarantee the removal of pain. Write this down somewhere, you will see it. Now, here's what you can do. I call this the informed patient protocol, and it costs nothing except the willingness to ask harder questions before you sign anything. Part 1. Get the evidence conversation. Before consenting to any elective procedure, ask your surgeon one direct question. What does the randomized controlled trial data show for this procedure versus non-surgical management for my specific condition? Not anecdote, not experience, peer-reviewed trial data. A surgeon who respects you will engage with this question. A surgeon who does not may not be the right surgeon for you. Part 2. Request a functional assessment. Before any joint surgery, ask for a referral to a physical therapist or physiatrist, a physician who specializes in physical medicine and rehabilitation, for a full functional movement assessment. You need to know whether the structural finding on imaging correlates with a functional deficit that surgery can address. Often, it does not. Part 3. Exhaust neuromuscular rehabilitation. For spinal and joint pain, a minimum of 12 weeks of structured, progressive neuromuscular rehabilitation under qualified supervision is not just a formality before surgery. For many people, it is the treatment. Not walking around the block, not the generic exercises on a printout, a progressive, periodized program targeting the specific muscles that control load distribution around the affected joint or spinal segment. Part 4. Get a second opinion from a non-surgical specialist. An orthopedic surgeon's job is surgery. That is not a criticism. That is a scope of practice. For a second opinion, seek out a physiatrist, a pain medicine specialist with a non-surgical background, or a rheumatologist if there is any inflammatory component. A different lens will almost always show you a different picture. Part 5. Ask the reversal question. Before any procedure, ask, if this surgery does not provide the relief I am hoping for, what are my options afterward, and does this procedure foreclose any of them? Spinal fusion, for example, changes the biomechanics of the entire spinal column permanently. Adjacent segment disease is a known and documented consequence. Knowing what you are trading is not pessimism, it is informed consent in its truest form. Maricel did only that. She asked harder questions. She requested the functional assessment. She followed the rehabilitation program. And 1 week into that program, she came back and said quietly, almost not believing herself, my hip was the problem the whole time. After 1 more month, she was off anti-inflammatories entirely. How old are you right now? Write it in the comments below. I want to see which age group makes up the majority of our viewers because it will directly shape what I cover in future videos. Here is exactly what to do after watching this. Step 1. If you are currently facing a recommendation for any of the 5 procedures I described, do not cancel your appointment and do not proceed without asking your surgeon for the trial data specific to your diagnosis. Step 2. Request a referral to a physiatrist or a physical medicine specialist for a functional movement assessment before any consent is signed. Step 3. If your surgeon cannot or will not explain the comparative trial data for your procedure versus conservative management, seek a second opinion from a non-surgical specialist. Step 4. Commit to a minimum of 12 weeks of supervised neuromuscular rehabilitation before treating surgery as inevitable. Step 5. Ask the reversal question at every surgical consultation without exception. Your doctor is not going to walk you through this at your next appointment. There is no revenue in it, and there is no time on a 12-minute office visit to explain the courage trial or the sport trial or what adjacent segment disease means for the next 20 years of your spine. The system is not designed for that conversation. I am Dr. Candace Miller, and I have spent over 20 years watching what happens when people consent to procedures before exhausting the alternatives. Most of the time, the damage, the hardware, the changed biomechanics, the narrowed future options was entirely preventable. The protocol I just described requires no prescription, no procedure, and no money beyond the cost of asking the right questions. It requires only the understanding of how your body actually works and the discipline to use that knowledge before you hand someone a scalpel. Subscribe to Dr. Candace, hit the like button, and help us reach 200,000 subscribers. Every person who subscribes makes it more likely that the next person who needs this information actually finds it before it is too late to use. This video is for educational purposes only and does not constitute medical advice. Always consult a qualified healthcare provider before making changes to your health routine or making decisions about surgical procedures.